breakdown in communication between first responders and treatment facilities. EMS takes on the characteristic of an expensive, inefficient, and error-prone set of procedures, where the breakdown in trust between the practitioner in the field and the provider in the hospital leads to a misunderstanding of the value that one presents to the other. This is really where things start to get interesting in terms of where technology can close that gap between the two. Just as a critical statistic, and I'll talk a bit more about some of the studies a bit down the road, the average data loss at handoff has been estimated on average to be about 46%. At the University of Pittsburgh Medical Center, again, one of the most sophisticated, generally seen hospitals in the United States, some experts in this space have estimated upwards of 80% data loss at handoff. But let's talk about the economics for a moment. Why this is a problem, beyond simply the clinical care, and of course, that's the reason we're all here today, but there's a financial incentive as well, and there's a process opportunity in terms of closing that gap and making sure that everyone is on the same page, not just with the idea of making care better, but also making care more affordable, increasing access, freeing up resources that would otherwise be lost or potentially wasted. For example, in Mesa, Arizona, it's a small town outside of the city of Phoenix, Arizona, United States. In 2010, the city identified 2,217 hours worth of waste, which they call duplicate documentation, data entry and documentation time. Ultimately, a study, or delving into this data, found that the documentation duplication time was 3.5 minutes per patient. So when we talk about the value of information and communication technology to have an outsized benefit, imagine the aggregated ability to leverage technology and take off 3.5 minutes. If you took 3.5 minutes per patient off that time, you would free up $115,000 in resources and be able to put 2,200 hours back into the system, where those resources can be spent for training, for example, focus on providing care and focus less on the documentation, the paperwork, quite literally associated with emergency care. And the CEO of American Medical Response, which is the single largest EMS provider in the United States, with roughly 10% of the market here, and is also the single largest private ambulance provider in the world, mentioned at the same conference that providers and payers are looking for technologies whether or not they can get reimbursed, because the waste is so rampant. Brazil, India, Singapore, South Africa, and the Middle East, areas that are really focusing on emergency with many large distances in between, air transports, for example, between Tanzania and South Africa, happening pretty frequently. Certainly in a country like India, where you have very large spaces. We recently had an expert in healthcare in India approach our company and ask how much it would cost to introduce 50,000 units of our software into the rural health market in India, because of the opportunities to connect the field and the treatment facilities that much more efficiently, leveraging your existing cellular network, leveraging the knowledge of technology that already exists in the country, but introducing those technologies with quickness. So to give you an idea of where technology can go, this is a slide that we usually use to describe our own technology. I'll leave that out for a moment. But we do want to emphasize that connecting the dots and recognizing the continuum of care is really where emergency response and treatment facilities will be able to come together. As some of you may know in the room, the accountable care model, or the ACO, as it's more fondly or controversially being known in the United States, is all about transparency. Yet when most lay people and even practitioners of healthcare in the United States and abroad today think of emergency services, they think of a linear practice. They think of one that starts when the patient calls 911, someone takes them to a facility, and off and off they go. Whether they are discharged onto themselves or to their family, or into a nursing care facility or some other place, the information goes one way. Whereas in point of fact, all the physicians in the room will recognize that particularly a high acuity patient, heart attack, stroke, transplant, some other high risk patient, and certainly chronic care patients are often going to be brought back into the care facility, readmissions, movement of patients from one facility to another. People need to understand what has happened to that patient, and information and communication technologies can allow that to happen while at the same time eliminating the need for manual processes. paper-based processes that, as you saw, are causing significant drain on an already cash-strapped system. So when it comes to what this technology needs to do, what it needs to be able to accomplish, we've identified 3 critical technologies when it comes to emergency medical services. And EMS is admittedly a bit unique in that it deals with field practice. It also deals with some of the most high-stress situations, including when a network may crash, a natural disaster, whether that be a tsunami, an earthquake, or a major car accident, for example. There are certainly high-stress situations. You need to be able to have the technology work during a disaster. This is a critical distinction and actually a critical error point in many of the technologies that are out there in the market, we believe, because any web-based solution is necessarily going to fail if it doesn't have some kind of local redundancy built into itself when the network crashes. In the United States, electronic patient care record industry, there are only a small handful, 3 or 4 companies that have built any technology that can work without an internet connection. That includes the use of GPS mapping technology. But if you were to find yourself in a hurricane, for example, and you can't get access to the network because the network's gone down, and your mapping capability requires an internet connection, you've got a problem. So working during a disaster is one of the key elements that we're looking for in the next generation of IT that works with EMS. Next, the technology needs to be intuitive. And the reason is actually because 2 and 3 here that you're seeing in front of you are linked. You need to be able to deploy this technology sometimes in seconds. And again, to be able to hand off that information to the next link in that chain, again, in only seconds. When you have 27 or more minutes in transit, and you have only 45 to 60 seconds in handoff, our objective is to decrease the amount of data loss so that EMS becomes a more trusted resource and really a hub of so much of what is going on in the healthcare system today, and certainly as it expands into the rural market, where it's going to be going tomorrow. Ultimately, the goals are several, but they would benefit everyone. In the United States, this has been the overarching, what's been known as the 3-part aim of the Center for Medicare and Medicaid Services and the Health and Human Services Administration, has been described as better care, better access, and overall better health. We've broken that out a bit more, which is what you're seeing in front of you. The first, to provide better care at lower cost, which at the same time will open the system to more resources, more patients, more efficient care, less focus on patient throughput, and better focus on patient quality. The second is to optimize the IT and the workforce productivity so that we have less data loss, need less redundancy, fewer systems, because the systems are being designed to work more seamlessly together. And what we actually as a company have spearheaded a cross-industry initiative that actually brings competitors together to work on these types of interoperability problems. We've called it tentatively the EMS Documentation Technology Alliance, or EMS Data for short, which has brought competitors together as well as very large companies and a number of hospitals to talk about how we can design solutions that will help us interoperate and rather than be redundant. The net goals here, after you've opened access and improved efficiency, is to reduce the liability exposure to the practitioner, enhance their interest in taking on new technologies, and of course, enhance the patient and provider safety. And we really emphasize both of these, because one thing that EMS in particular suffers from is a lack of awareness around just how mission critical they are. The fact that healthcare and public safety really come together, where if healthcare suffers, public safety becomes strained. If public safety suffers, naturally healthcare is going to go as well. And we believe that next generation communication technologies, information technologies are really the key here. Finally, I want to tell you a little bit about the work that's been going on in this area currently as well as in the past. We are engaged with a number of partner institutions on studies that look at a number of critical areas to this subject of bridging the gap between first responder and treatment facility. Pre-hospital documentation time and expense, again, looking at the efficiencies. The medical errors attributed to handoff, especially if it's a manual handoff process. The turnaround time associated with that process, again, these two being definite.
Sorry, Mr. Jonathan, we are running short of time, so you may have to conclude.
Yep. to take a look at details of these studies. We've cited a number of them right on our website at beyondlucid.com, where you can link right to these studies and see for yourself the types of research that's been done in the past, which has been largely hyperlocal. There is certainly room for additional research in this space, and especially porting current technologies onto the international marketplace. So with that, thank you very much. I'm just going to go back here. If there are any questions, I'm certainly happy to answer them. And thank you very much for inviting me.
That was Dr. Jonathan from the US on video conferencing. So we would, before the next session starts, we would have about 5 minutes or so for the question and answer session. Any questions to any one of the panelists out here?
My question is to Dr. Ramakrishnan. Why is it that most Indian hospitals, including the best hospitals in the country, are not implementing CPOE? What do you think as a critical care specialist is the major reason? And what should be done to actually change this? I mean, because we keep constantly, saying government hospitals are not doing this, government is not doing that. But, this very similar situation is present in many of the super specialty hospitals.